Hi, everybody. Everybody comfortable? A little hot in here? Or it's just me? Running up. So, everybody, residents and interns. Who are interns here? Interns. And third-year residents? 2. And the rest are second year. Any students? Some students. Okay. All right. So the scapegoat is the student. All right. So Dr. Hassan, I'm one of the interventional cardiologists, and just wanted to go over some cardiac emergencies that you guys will come across, especially in the first year when you're running to an RT or you're being called to see this unstable patient. Just what should go through your mind, and what should you be thinking of when you're assessing the patient. A lot of the time, if you think of something, then you will probably look for it. If you don't think of something, you may not look for it. So this I can assure you, this talk is purely clinical. There is no trial data presented in this. There is no epidemiologic information also. So just clinical. All right. Now, cardiac always becomes an emergency. Anytime there is a cardiac issue that you are calling a cardiologist for, it's pretty much an emergency already. So, sometimes it's not. And that is also a thing that we have to identify: what is an emergency, what is not. Sometimes you're attending will call, the troponin is positive, and then, call a cardiology right now. And then, you have to understand how significant is that troponin bump that you're rushing to call, right? So should you panic and leave everything else and then call it? Or so say if a troponin is 0.5, and you don't have to rush to do it. So again, all cardiology stuff can become an emergency, but it may not be an emergency right at that moment. So to go over what could become an issue, right? So patients don't come in telling you that I'm having a heart attack, or I'm having a PE, or I'm having an aortic dissection, right? So they come in and tell you symptoms. If patients come in and tell you that they're having something, it may or may not be true, because either maybe the patient just looked it up and she's having a heart attack, so she comes and tells you that, I'm having a heart attack, I think. So it may not be true, but we don't always take patients' word for it, as going through it. So you overheard the page go off. It's code blue, cardiac arrest. So, we all did ACLS, VLS, and we know that shockable, non-shockable rhythm, VTAC, VFP, AC, or respiratory arrest. Now, depending on which floor you're being called, you can actually prepare yourself what you're going to see when you get there. So you don't know all the floors yet. The third years may know. So if it's an orthopedic floor that you're called, for a rapid response, or code blue, right? So two things come to my mind. What are you guys thinking? PE?
Narcan.
Huh?
Narcan.
Narcan. So either too much pain meds, or it's a PE. So if it's not an immediate surgery happened 3 days ago, and now it's, or too much pain meds and now she's not breathing. So these two things. If it's 3 PE, heart failure floor, and you have a cardiac arrest, what comes to your mind first? VTAC and VFib, right? Because it's a heart failure floor. There are more people there that will have a low EF and a higher tendency of having something like that. If it's a 5 St. John and you have a cardiac arrest, chances are it's probably PE or AC, because there's usually somebody who just got out of ICU from sepsis, went to 5 St. John or 4 St. John, and now she's either deteriorated overnight, nobody really paid attention, and now cardiac arrest. So this is what we call an educated guess, right? So what kind of patients population are there? What are the substrate there? And then you think of it as you're running there. Okay, I may have to check the blood sugar first, because the 5 St. John, the diabetic floor, maybe they give too much insulin, and that's the. So cardiac arrest and respiratory arrest, what you may call it. So this is your thought process as you're heading there. And trust me, Hackensack is a big hospital for interns. you may lose a few pounds just from running from 9P to 5 St. John, right? So chest pain, most common symptoms that will come to cardiology. It's our duty to find out, is it really an emergency or is it just an alcoholic having gastritis, right? So both are chest pain, and both could be dangerous. One could be having GI bleed and having chest pain, and the other one could be having an MI. And it's simple if one didn't have any problem with the other, but a lot of the time that alcoholic also had a stent 7 days ago, and now you don't know what is happening. Is it his aspirin and Plavix giving him bad GI bleed and gastritis? Or is it like, he had GI bleed, they held the Plavix, and now he's having an MI, right? So it could be both sides. So rarely patients come as only one diagnosis, right? That's it. It's only COPD exacerbation. You will see almost always COPD exacerbation is being overlapped by CHF exacerbation, right? Or a pneumonia or something else. So clinical picture never is as simple as we go through it. So I want to look at patients from symptom, not by diagnosis. So this patient, when you hear, oh, this is a CHF patient, the first person who says that, okay, this is a CHF exacerbation, and everybody just passes that same diagnosis along. And sometimes it's the resident or the intern that has to think again and say, okay, he has a history of CHF, but he got so much diuretics since he came in and he's still short of breath. Maybe it's not CHF exacerbation, right? Just because the chart says his ejection fraction is 40% doesn't mean every time he's short of breath, he will be in CHF exacerbation. It could be RSV, right? Causing pneumonitis. So, just having an open mind is what I want you guys to have during these 3 years. And as you specialize, you're only gonna get tunnel vision. So it's important to have an open mind when you're training so you can think freely and not through like a glasses of a cardiologist or a pulmonologist. Shortness of breath. As much as it could be a pulmonary symptoms, it could definitely be a cardiac symptoms. It could be a sign of valve disease or acute mitral regurgitation from an endocarditis that perforated the mitral valve and now she has a wide open MR. That's an emergency because she's in flash pulmonary edema. Or it could be just COPD exacerbation that the patient also had even before he had the endocarditis. So, it's our job to figure out which one it is. And as long as you don't treat the right cause, patient will continue to have symptoms. So shortness of breath is another symptom. Sometimes in diabetics, having an MI, the only thing they present with is shortness of breath. It could be pulmonary edema, it could be drop in EF from MI, but it could be shortness of breath that they're presenting with. Palpitation, it could be as simple as PSEs causing palpitation, or it could be VTAC causing palpitation. Patient could be talking to you in VTAC, having palpitation. It's possible. So VTAC doesn't always mean that you have a cardiac arrest. VTAC could be pulse with pulse, could be without pulse, right? So that's when we differentiate the treatment of VTAC also. Anyway, we come to that when we... Unstable vital signs. Rapid response, nurse is not comfortable with the heart rate of 140. You go in, you look at it, it's atrial flutter with 2-to-1 conduction, it's a heart rate of 150. Or AFib, most of the time, right? Especially in the older patient group. It's almost an epidemic of AFib if you walk into the hospital. Everybody has AFib. So you got to find out what unstable vital signs are from. Is it because their blood pressure is 220 over 140 that they can't breathe, or it's something else that's happening? So unstable vital signs is another. I called it symptom, but occasionally it's the reason for the call, right? And then loss of consciousness. So they passed out, and now you have to assess whether it's an arrest or it's just like he passed out, be it syncope, or because he had a run of VTAC and he became hypotensive and he passed out. So what was the reason for this loss of consciousness? So these are the symptoms that I think constitute an emergency or may constitute an emergency when you guys are called to that floor or to the patient's bedside. Busy slide. And again, we will go through one of them. I just listed everything that came to my mind that we deal with in an emergency situation: coronary disease, decompensated CHF, arrhythmias, valve disease, severe pulmonary hypertension, pericardial effusion, blood pressure problems, or some pulmonary issues that could cause cardiac decompensation also. So my slides are not fancy. No cartoons popping up in between. So feel free to stop me if you need a breather or before you feel pre-syncopal, so we get you fresh air. All right. So coronary artery disease is something that we always deal with, and we have to differentiate whether it's stable versus unstable. So if it's stable, when can it become critical, right? So a lot of the time, our patients on 3PW, post-cath patients, waiting for surgery, right? Those are the most critical patients, that they need open heart surgery, but they're waiting on 3PW. For the nurse, it's another patient that's post-cath, right? But we actually lost a patient because the patient went to the shower. He was waiting for surgery 4 hours later. So he went to take a shower. It was a hot bath, and then he dropped his pressure. He coded in the bathroom. We had to drag him out and code him on 3PW hallway. So since then, I say there is no stable coronary disease that's in the hospital. Yeah, stable coronary disease walking outside, they're stable. But if they're waiting for surgery, they're probably not stable, right? Or they're stable until something happens to them. So left main stenosis, critical left main disease, 80-90% blocked left main. Severe triple vessel disease, going for surgery. And again, double and single vessel disease, they're not really that critical, but it could be. It could be proximal LAD that the patient needs a stent. And because the renal function was bad, they didn't do the stent that day. They're going to take the patient back tomorrow to do the stent. So it's very important to find out what's happening with the patient. But it's hard. When you get called in an RRT, you don't really know what's going on with the patient. So you have to find out what's going on within 5 seconds. So these are apparently stable patients that could turn into unstable patients. We all know STEMI is an emergency, and they're having chest pain or severe shortness of breath. You do an EKG, you see ST elevation, you're concerned, and then you call cardiologist on board or on call for STEMI, and they will come and take the patient. And they could be inpatient too. Not all STEMIs are coming through the emergency room. They could have STEMIs on the floor. Now, ST elevation may also be that the patient came in with a STEMI yesterday. They did the stenting in the STEMI artery, took care of that, but there's still ST elevation, right? This happens a lot. So it's not like they come in with an ST elevation, they open up the artery, and the ST elevation is gone. So ST elevation can still be there. Sometimes it didn't resolve because the flow wasn't very good even after stenting. Sometimes there could be aneurysmal change, and we know that LV anterwall aneurysm gives anterwall ST elevation. Now that ST elevation looks concave, convex rather, and then there will be sign of previous Q waves or stuff like that. So it's important to know that is that ST elevation before or is it new, right? We get called, and even from the emergency room, they have called ST elevation without looking at prior EKGs, but that ST elevation is from LV apical aneurysm or LV anterwall aneurysm. So STEMI. NSTEMI, who thinks NSTEMI is less complicated than STEMI? Anybody? Well, I thought it like that because it's a non-STEMI, so it sounds less of a problem, right? But sometimes non-STEMIs could be worse than STEMIs. STEMIs could be one vessel. Usually, it's either RCA or the CERC or the LAD, but non-STEMI could be left main. Non-STEMI could be any of those that's not showing up on the EKG. So it could be a completely occluded artery. So non-STEMI doesn't mean that there is still flow. It could be a completely occluded artery, but EKG is not picking it up. So that's what sometimes the limitation of EKG is, because there are some areas of the heart that doesn't show up on the EKG. So EKG is like 12 leads, like 12 of you sitting around, right? And then this is the heart right in the middle. So when she's looking at it, she's looking from this side. But when I'm looking at it, I'm looking at it from this side, right? So that's what basically the EKG leads are doing, right? So they're looking at the heart from different directions. Sometimes no one is looking from this direction, right? And if there is an infarct in this area, no one's looking. So there will be no changes, right? No one would know. None of the leads will find it. So that's what NSTEMI may be. It could be an OM, it could be a CERC, it could be a branch of RCA. You know, it could be any of those arteries that give no changes in ST segments on EKG, but it's still 100% blocked artery. So non-STEMI is no way less significant than a STEMI, or it could be, right? So somebody who's 89-year-old has tons of blockage, had no troponin elevation, and now because she had a sepsis, her pressure dropped, so demand ischemia, and now has a troponin of 1, right? That's also non-STEMI, demand type 2 MI, but it's not because an artery is 100% blocked or a major artery is 100% blocked. Could be a branch, could be a small artery that, you know, is not hemodynamically affecting it. It's not showing up on EKG, but you have a reason. There was increased demand either from pneumonia or sepsis or what it may. Unstable angina, they're having chest pain, but there is no troponin elevation. You may or may not have EKG changes, as you all know. Treatment, I'm not going to go into because you have already read through it, you know, how to treat MIs and all that. This is more to focus on your attention towards the clinical scenarios that you will encounter on the floor every single day, and how to think when you encounter one of those. Any question? Who knows how to make it go forward? Okay. Shortness of breath, and then you get an X-ray, and you see white out both sides, right? Upper lobe diversion, a lot of white, fluffy shadows, and patient can't breathe, tripoding, right? Even on oxygen, because she can't even take the oxygen. How do you treat that? What is the first 4 steps you're going to be doing?
Oxygen,
Mm-hmm.
diuresis,
Maybe intubation.
Intubation, if needed. Blood pressure control, if the blood pressure was super high. Lasix, if patient will need Lasix in that case because can't breathe, so you got to get as much fluid out. Morphine, sometimes morphine helps. It causes pulmonary venodilatation. Nitro helps, right? Nitrate helps. So tell me 2 patients that can die from nitrates. Anybody else? Aortic stenosis. Which one? Right-sided heart failure. Anybody else? Severe pulmonary hypertension, like, you know, peer pressure of 90. Give them nitro, they're gonna die. So HOCM, aortic stenosis, good one. Right-sided heart failure, may not die, but obviously the pressure is gonna drop. Critical aortic stenosis, they won't come back. So, you know, but the complicating factor is, what is the symptom of severe aortic stenosis? One of the symptoms is chest pain, because their demand on their LVEDP is so high because they cannot pump across the tight aortic valve. So their LVEDP is high. They may also have coronary disease, and you don't know the patient. You're called because the patient's having chest pain, and you walk in and you give first sublingual nitro, right? And patient was killed by that. I say killed because we did it, or rather, easier way to say is patient died after we gave nitro. And it happened even in the cath lab. So, you know, it's very, very important that we before you pick the nitro to give it or tell the nurse to give it, just ask or look if there was any history or any echo that showed critical pulmonary hypertension or critical aortic stenosis. The other patient that is a problem is critical left main stenosis. Obviously, they're going to have chest pain if they have critical left main stenosis, but nitro, sublingual nitro specifically, may actually make it worse, make the patient worse. The reason I say that is sublingual nitro is like a rapidly absorbed 400 micrograms of nitroglycerin. If you give somebody like, transdermal, like nitro paste, it's rather slowly absorbed. So it also can cause the damage, but it's not like rapidly absorbed that it causes a sudden drop in blood pressure. But if you put it under the tongue, that mucosa absorbs everything right away. The tablet is gone. 400 micrograms sometimes is a lot. You look at it 0.4, it sounds small, but it's 400 micrograms. In the cath lab, we never give more than 200 at a time. So be careful because it's very well absorbed. So you guys treated the flash pulmonary edema because these are the few things that could put the patient in flash pulmonary edema. Massive MI, enteral MI, which will probably already be noted. Complications. What complications could cause flash pulmonary edema? MI complication. VFib. VTAC can. VFib, they will probably die of cardiac arrest before. VSD, post-MI VSD can cause acute pulmonary edema. Acute mitral regurgitation, meaning their papillary muscle got necrosed. So then there's acute severe mitral regurgitation, they go into flash pulmonary edema. Or LV rupture because the patient presented late. And then that area of myocardium is necrosed, it's friable, and it just let go. Called severe LV systolic dysfunction can also cause flash pulmonary edema if they suddenly go into VTAC or if they suddenly go into rapid AFib, they can go into pulmonary edema. Tachycardia, severe AS, severe AI. I should say severe acute AI, right? What gives you severe acute AI? Aortic dissection can give severe acute AI if it involves the valve, right? So aortic dissection. What else can give you severe acute regurgitation? Acute aortic regurgitation. Aortic valve endocarditis, right? So it was just holding off, and right before you walked in, the valve either perforated or got chewed up, or something happened that the valve is now wide open, and now there is AI. Severe AI patient is one of the sicker patients of any valve disease because you cannot really do anything for them other than putting in a new valve. Balloon pump, you cannot do. Impella, you cannot do. Dialysis is not going to help, let alone giving some Lasix. So acute AI is a very, very sick patient that need to go to the surgery right away for a new aortic valve. Severe MR, again, I should say severe acute MR or severe MS in itself should not, mitral stenosis should not cause pulmonary edema, flash pulmonary edema, unless they go into rapid AFib, right? And again, I don't want to go into details of pathophysiology. If we come across any patient or one of your in, we'll go into details discussion, or the person who's going to discuss mitral stenosis will go through that. Pretty much what we discussed, right? So I have this issue about CHF. When we call CHF, what do we really mean, right? Congestive heart failure. So the heart is failing to do what? Either to contract, which is a reduced ejection fraction, or to relax, right? So which is preserved ejection fraction. But until you say that, not all CHF patients are the same, right? Some could have aortic stenosis and short of breath, and we call it CHF. We call it diastolic heart failure, but that shortness of breath is not from CHF. That shortness of breath is coming from the aortic stenosis. So there is no reason to term everybody like, HFpEF, other than having severe diastolic dysfunction, we shouldn't even call it HFpEF because then we have a reason for their shortness of breath. We have a reason that the patient is in AFib rapid AFib, that's why they're short of breath, not because the LV is stiff. Yes, LV is stiff, that's why they got the AFib to begin with, but it wasn't short of breath 5 minutes ago when the patient's heart rate was controlled. Now the patient's heart rate is 160 and he can't breathe. So, obviously, so diastolic dysfunction, again, a lot of the time on echo, we see stage 1 diastolic dysfunction. That's probably not the reason of somebody's heart failure. Unless you see restrictive diastolic dysfunction or grade 3 severe diastolic dysfunction, it's probably not causing the symptom. Probably there's something else that's happening. But again, diastolic dysfunction, valve disease, and arrhythmia are usually the cause for HFpEF. And HFrEF could be non-ischemic, ischemic, and no, what happened? All right. Arrhythmia, tachy and brady. So again, we're talking about cardiac emergencies and what constitute an acute cardiac emergencies. I pretty much listed every diagnosis that's in the book, right? SVT is one of the common reasons that patients call 911. Usually a younger or healthier, usually female. Females have more SVT than males because their heart rate is running at 300 and they can't breathe, right? By the time they come to the emergency room, EMS has already treated the patient with an adenosine or cardizem, and they have converted. So you don't get to see SVT all the time. But sometimes patients who are here will develop SVT because they have respiratory issues. So these are all SVTs, all because of abnormal circuits inside the heart that can cause AV NRT or AV reentrant tachycardia. So not to go into complex EP stuff. Acute treatment, rate control, when you get called for these, could be atrial flutter or fib. When would you shock a patient with AFib? If they? Unstable. So unstable meaning what? So hypotensive. But I have seen many a time that patients are on pressors and they're also on cardiocentric, right? Doesn't make that sense, right? So it doesn't make any sense at all. But it's done, and you will see that because the patient to decide whether I should shock the patient or not shock the patient is a big decision. It's not like, okay, should I hang another cardizem drip or should I just go up to 7.5 and see? And sometimes we do say that, if you slow down the heart rate, the blood pressure may come up, but not in a patient who's requiring 30 of Levophed. So, that's way beyond the scope of any cardizem. So if those patients are in AFib, maybe cardioversion is a good, but then with cardioversion comes the problem of anticoagulation. Should I rule out a clot? And there we go. Then should we even think of cardioversion, because now we need to do a TE to rule out clot. So every one step calls for another, and then the decision becomes more difficult. If the patient is unstable and knowing that there could be chances of a clot, but if it happened within 48 hours, you could safely go ahead and cardiovert, right? Because the AFib happened within 48 hours. White complexes. So whenever we get called for white complex, the first thing I want to know is whether they had a white complex before, right? So if the patient had left bundle branch block when they were walking around happy at home, doing nothing, no symptoms, and now they come in and they have, say, atrial flutter, right? Rapid atrial flutter. Their complex would still be white because they had a white complex to begin with, right? So that atrial flutter would look like VTAC if you didn't know that the patient had white complex before, right? In the emergency room, patients have been shocked for sinus tach with left bundle branch block. Because when you see that white complex tacking away at 150 or 200, you can't wait for the electrophysiologist to come in and tell you that, okay, no, the direction of this is actually coming down, it's not going up. So the vector, sometimes in those EKGs, if you look from one lead 2, and see that it's coming down towards lead 2, meaning it's positive in lead 2. If it's positive in lead 2, meaning that the QRS is coming down, chances of it being a VTAC is less. It's possible, but it's less because it's coming from above downwards, right? If you see it's negative in lead 2, that means the QRS is going away from lead 2. That's probably originating from the ventricle, right? If it's originating from the ventricle, it's possibly VTAC, right? So white complex, rather than going into multiple, like, mapping algorithm of the VTAC, if you just look at one lead 2, if it is positive in lead 2 or if it's negative in lead 2, that tells you a lot. Then comes the problem of RVOT-VT. Happens in young patients. I had 2 patients with 42-year-old with RVOT-VTAC. Why do I say that? Because that VTAC originates from the RVOT and it comes down. That's the only VTAC that comes down from above. So RV, outflow tract to downwards, and will be positive in lead 2. So the only VTAC that's positive in lead 2 is RVOT-VT, which is usually not our usual VTAC patients. It's rare, and it's usually younger patients who has no other heart problem. Our usual patients with low EF and other heart problems, they usually have a VTAC that would be negative in lead 2 because it's coming from the ventricle going upwards, or spreading around in the air from the ventricle. So as I say, that's why it's VTAC. But all of the above, SVT, flutter, fib, with previously existing bundle branch block, will be white complex. Or if they have a fib or a flutter, and then they have a WPW syndrome. Who can tell me about WPW syndrome? It's a very favorite in the tests, but you don't see it in the hospital as much. So they have accessory pathway, right? Delta wave. So they have an accessory pathway. So rather than going this way, which is the highway, I call the AV node the highway, right? And then it breaks out into Purkinje system. Those are all highways. Highways because it travels faster through the highway. If I have to take a detour and go through local way, it takes me longer time, right? It takes longer time to take local roads. So if someone's watching you, timing you, say for me, my wife is timing me how long it takes me to get home, right? So if she's timing me and it's taking longer, my excuse is I took the local way, right? So EKG, in EKG, because the wider it is, meaning it's taking longer time. Longer time meaning it's going through the muscle, it's going through the local roads, right? And that's why it's wider. Why can't it go through the highway? Because the highways are blocked. Left bundle branch block, right bundle branch block. So it's going through the muscle, that's why it takes longer time. So why is it blocked? Because either they have some conduction system disease, or they had an MI that infarcted the highway, or it's just an electrical system problem, right? So it's not, or it could be sarcoidosis, or it could be some other infiltrative disease that causes fibrosis of these highways, and now electricity can't go through the highway, so it's going through the local. So big words for something simple, right? So WPW is an extra pathway, right? So you could go the highway, or somebody build a bridge around, right? So it's a bridge basically, right? It's a bypass track or a bridge. So what happens? You don't have to go through AV node. So AV node is a gate. So it watches everybody's ID and lets it pass. So it takes a little time. So there's AV nodal delay. If you have a bridge or a bypass, that has no AV nodal delay. So it goes fast. It goes fast and catches on to the highway after the AV node, right? So that's why You see the delta wave. The delta part is the bypass part. And then it goes to the regular. So if it goes down that way, is orthodromic. But sometimes you have a bypass tract here. So you go down this way, and then it spreads, and it comes back into the atrium through this bypass tract. So that's antidromic, right? It's coming back to the atrium through that. So that bypass tract could be used to go down, or that bypass tract can be used to come back into the atrium. So depending on which direction the bypass tract is taking the impulse, it's either orthodromic or antidromic. You get my point?
Yeah, but I was kind of getting confused. It's like it's the antidromic
Mm-hmm.
reentrance,
Mhm.
same thing as it's like
So WPW can cause both. So WPW just means that you have a bypass tract. So you could have antidromic conduction, or you could have orthodromic orthodromic conduction. So you could have both conduction through the bypass tract, because it's a dual. It's a what do you call like, you could go this way and that way. So it's a yellow line. So you could go in and out, right? So but again, that's going into detail. So if AFib with WPW, the EKG will be white complex, irregular, white complex and irregular. That's when the patient did not have white complex before. That is, you have to think of the AFib with WPW. Bradycardia can also constitute that emergency, that patients come in, or the nurse sees a heart rate of 40. So a heart rate of 40 can be sinus bradycardia. It can be complete heart block. And again, without looking at EKGs, it's gonna need at least 10 minutes of discussion on how to differentiate. It's easy because there's no P in front of every QRS, right? That we all know. But when we look at the EKG, it doesn't always turn out to be that easy to find out. And trust me, we all struggle sometimes. So you have to establish the relationship between the P and the QRS. And again, we can talk about it in a different discussion. As much as frequent PAC, I just got called yesterday from OR because they induced the patient for cervical spine surgery. Patient went into PAC and the heart rate was 40. Because after PAC is a pause, and the pause was so long that the patient's heart rate was 40. So sometimes atrial bigeminy or ventricular bigeminy can cause, when you look at the monitor, you see a heart rate of 80. But when you're looking at the pulse ox, you see a heart rate of 40. Anybody explain that to me? I look at the heart monitor, I see a heart rate of 80.
They're not all conducting. I mean, they're conducting, but they're not all causing contraction.
Causing the contraction strong enough. They are causing the contraction,
Strong enough.
but not strong enough to make it all the way up to here, right? But your pulse ox is here. So you look at your, next time you see a ventricular bigeminy or atrial bigeminy, you look at the heart rate on the monitor. That's your heart rate from the EKG, right? So you see it's whatever, 80 or 90. And then you look at the pulse heart rate, you see it's exactly the half, because every other beat is not conducted in a pulse, right? And when I talk about it, I usually talk about that wave when people go to the water parks. Remember, they have those waves. Not all of those waves come to the end, right? So if you stand at the end, you don't know how many waves were really created. Only the strong ones would reach to the end. But the younger ones that are farther in the front, they will get hit by all the waves. So usually it doesn't cause any problem to the brain, because the brain being closer gets all those waves, so they are not passing out. But the anesthesiologist was about to pass out because he got concerned that it's only 40 and the patient's gonna code or something like that. So she aborted the surgery, and then emergency cardiac consult or a PSC. That's how a simple thing like PSC can become a complex scenario that everybody is panicking, like throwing troponins and echocardiogram. It was a simple PSC. Happened yesterday.
Sorry, quick question.
Tell me.
Can the WPW present as narrow complex?
So they can have narrow complex where we call it the WPW is not, it's hidden or it's not already expressed. So I may have WPW syndrome and not show it on the EKG, right? But when the heart rate goes up a certain degree, or there is some abnormal electrolytes, then only if I start conducting through the bypass tract, you will see that delta wave. So if you don't see a delta wave today, doesn't mean that the patient didn't have a delta wave sometime before, or doesn't have the WPW. You see what I mean? So if someone's having palpitation and you do an EKG and you see a normal EKG, of course the patient doesn't have a WPW. But if you see a delta wave in that EKG, yes, he does have a WPW syndrome because he's having palpitation and he has a delta wave, right? That delta wave may not be there another time, depending on the heart rate, depending on the electrolytes, on the impulse conduction velocity. That WPW delta wave may not be there all the time.
So what if they have like an intermittent WPW wave or delta wave like on the resting EKG, and they come in with like narrow complex SVT or something like that?
So that if they so that's the question. So a lot of the time when they have already diagnosed WPW syndrome, when they go fast, they would not be narrow complex. They would be wide complex. If they already had a delta wave in the resting EKG, and rapid rates only make it express their delta wave, right? So rare, I don't think it's even possible that if you have a bypass tract and your rapid, let me see, it's possible because if you're doing retrograde conduction through it, antegrade is through the AV node and retrograde is coming through the bypass tract, so it's possible to have a narrow complex with a WPW. So in that cases, we usually don't block the AV node. I think that's what you're alluding to. Those patients are better treated with amiodarone, not beta blocker. So if the patient has a known history of WPW and you see them come in with the tachycardia, we usually avoid anything that would block the AV node. So what would happen is, I'm going more into EP now. That would block the AV node and allow more conduction down the accessory pathway. And then if the patient had an atrial rate of 300, there is nobody checking their ID at the bypass tract. So all 300 will go through that bypass tract and the patient could go into VFib because it's too much of impulse coming down. So again, guys, there will be other cardiologists covering these in detail. So, these are rarities but important because first of all, it's tested heavily. Should you give beta blocker in somebody who has WPW syndrome? So they'll give you an EKG of irregular white complex, right? With the previous EKG. This was his EKG before and now he has this EKG. Which medication is the next step in treatment, right? And you're not going to pick anything that blocks the AV node. Again, I think we talked about most of this. Valve disease could present as cardiac emergencies. Severe mitral stenosis, severe MR. Even severe acute MR could be from endocarditis also, that they ruptured a cord or they ruptured a papillary muscle and or they have perforated the valve leaflets and now they have severe acute MR and they're in flash pulmonary edema. So valve diseases can cause it, an acute presentation. Severe pulmonary hypertension usually does not cause acute cardiac emergencies, but they are always short of breath and they probably when they're in the hospital, they already have the diagnosis by echocardiogram or by right heart cath. So just wanted to put it out there, and then the WHO classifications. Usually we are concerned about group 2, secondary to the left side, but the sicker ones are probably group 1 because there's nothing too much to cure them. We can only control it, but it's pericardial effusion. When would you suspect I already told. Oh, well, when would you suspect somebody in pericardial with that the patient may have pericardial effusion? What is their symptom? What is the symptom of pericardial effusion? Symptoms? What are they gonna come to you with? Shortness of breath, right? Sounds similar. Somebody with pneumonia could come with the same, right? Or somebody with lung cancer could come with the same. So you have to suspect. So it's not that you're gonna pick up right away because it doesn't show up on X-ray. Everybody's heart looks globular, you know, and on a portable X-ray, you cannot really comment about somebody's globular shape of their heart, right? So you do an EKG and you see what? No, PR depression is pericarditis. Low voltage. So low voltage, and you could also see if it's like doing this, then you know you could see QRSs looking different every other beat. But low voltage is the first thing. But guess what? Look at our patients here. They're all 400 pounds, and they all have low voltage EKG, right? Because between the lead and the heart, there's a lot of stuff, right? So it could be low voltage, or it could be because he's a smoker for the longest time and he has a lot of air in his lungs and it's low voltage. So low voltage, if you see low voltage, you suspect it. He had an airbag injury, suspect it. He had a complicated PCI with 3 wires, and one of the wires poked a hole in one of the arteries and it was trickling, and then he was on heparin drip and aspirin and Brilinta. That hole never closed, hole in the artery. So now 3 hours later, patient has a pericardial effusion and tamponade. Or the patient had an ablation, AFib ablation, done a lot of the times in this hospital, right? They burned the atria during ablation to get rid of AFib. One of the burn was a little too much and perforated the atria. Atria has a low pressure, so it's not like pericardial effusion right away. And the leak wasn't like a big rupture of the atria, so they may have pericardial effusion 4 hours later when the cardiologist is home, but you guys are here, right? So you have to figure it out. So that, or malignancy, you know, pulmonary, like, you know, any lung cancer, very high chance of they may have pericardial effusion. So think about it. If you don't think about it, you're not gonna order that echocardiogram, which everybody else would be getting, right? Everybody gets an echo in Hackensack Hospital who walks in, except for the one that has the pericardial effusion. So what is the clinical sign? And I'll let you guys go in 2 minutes. How do you differentiate if somebody tells you, even CAT scan tells you there's pericardial effusion, and then you are there to find out if there's a tamponade or not. So what is the hemodynamic situation? It could be hypertensive or not. What is it? What is pulse? You have to explain that. What is pulsus paradoxus?
So like normally you have a high blood pressure because of very inspiration expiration.
Mm-hmm.
So in the situation of like cardiac tamponade, when you inspire, you'll have blood coming in, which you can't accept. It's gonna bump into the interventricular septum.
Mm-hmm.
It's gonna cause less preload to the left heart. So you'll have less blood coming on their pumps. You'll have a drop of more than 10.
Okay, so what essentially you will see is a drop in blood pressure.
Yeah.
When? During
inspiration.
During inspiration, right?
Yeah.
That's exactly what pulsus paradoxus means, right? So how do you demonstrate that?
So you go down to the pulse spot. Like once you fill up the BP, you go a little bit higher than the sound that you cut off, and then you let it go, and pretty much you don't have to make them take a deep breath in. You kind of just get to the point where you start hearing it, and you start seeing the fluctuation.
This is very important. And which year are you?
They're medical student.
You're a medical student, so very good. So in the longer we go out of medical school, we keep forgetting. Yeah. So how you do it is exactly what he says. So you take a manual cuff, right, and try to find a manual cuff in Hackensack Hospital. So you won't find one. So find a manual cuff, put it up, and then as you're taking a blood pressure, you come down where you first hear the cord cuff sound, right? So you hear the cord cuff sound, say at 100. You leave it there, you tighten it. And then you just watch the patient breathe. Takes a deep breath, you don't hear it anymore. Why don't you hear it? Because his blood pressure is now 80 and your cuff is at 100, so you don't hear it. And then he breathes out, and then you hear it. And then again, he breathes in, you don't hear it. So that's what he meant by saying, you know, their pressure drops, because you can't really measure pressure during inspiration and expiration, and that's not how you see it. So you hold it, and then you try to hear the Kharkov sound as he breathes. So that's a sign of what medication you should not be giving in a patient who has pericardial tamponade. Remember, he's short of breath. Which one? That? Lasix, right? Why wouldn't you give Lasix to that patient? Decrease their volume, and their RV is going to be even more. But what do you give when you walk into a patient who's short of breath? Right? So these simple things, again, giving Lasix, you're not killing him. You can always give him some more fluid. But you walk in and you see somebody who can't breathe, the first thing you tell the nurse to give is Lasix, right? Sometimes even 40 Lasix, 80 Lasix, right? But, you know, so that's why. So I just want to bring these up because these are like, you know, kind of contradictory things, but we do it all the time. AS patients will complain of chest pain and you will give nitro. But we have to know that it's AS and not give like a jolt of 400 micrograms of nitro, drop their pressure, and they can't come back from it. Of course, echo will show it, chest x-ray clinical signs. I think we covered every diagnosis in cardiology. We touched upon, and we didn't go much details into because each one of them. So, you know, a lot of the time reading a chapter on pericardial tamponade is good to know it, but you have to think about it first, right? So that reading part you can do at home, but thinking about it, you have to see patients. And once you see a patient, you're not going to forget. And then you're going to think about it, right? So that's why the residencies is important, because the more you learn, once you graduate out of residency, you know, you have an ego, right? You can't go and tell other attending, oh, I don't understand it. But as a resident, as a fellow, you can say I don't know, and you can ask questions. Even as an attending, you can ask questions. I'm just making it too dramatic. But, you know, the point is, this is your learning time, and the more you learn it now, the better, the more comfortable you're going to be. And patients tell you a lot. So listen to the patient. Questions? No? All right. So, yeah, if we